So, I'll be talking about understanding Rinne's and Weber's tests. Um, Next, please. So, why this test? This test is a very, very essential test with ENT, and as we know that a high percentage of our cases, as in the primary care as GP, are ENT cases. So it's quite very important for us to master days and know about Rhinus and Webers. It helps to assess hearing loss, and not just that, but to differentiate between which types of the hearing impairment. And we've got two, main types of hearing loss. It could be a conductive hearing loss, which could be a problem either in the outer or in the middle hair. And it could be sensorineural hearing loss, which could be issues with the inner ear or problem with the nerve, auditory nerve itself. Next, please. Right. So Rhinus. So for Rhinus, what do we need? We basically need our tuning fork, and it's a specific tuning fork, which is the 512 hertz one. And the steps for us doing this test. One of the main thing about the Rhinus test is it will help us to differentiate between, is it a conductive one or is it a sensorineural hearing loss? And this is because it assesses the conduction through the bone and the conduction through, the hair as well. So how we go about this is you strike your tuning fork, and then, and it's always said that you should strike on your, on your own tie. And I just think, because striking on the table and all that, that could, startle the patient, but these are just different nuances. So you strike, and then you place the base of your tuning fork on the mastoid bone, on the mastoid process, well, the mastoid bone. And this we tell us, we're checking the bone conduction at this point. So you just let the patient know. And again, like every examination, it's always good to just run through the process with your patient first. This is what we're doing. Obviously, we take our consent and then explain that this is what we're going to do. This is what I'm going to do. And this is what response or what I expect from you. So once we strike, we'll place on the mastoid process, and then you ask the patient to indicate when they no longer, hear the sound. Now, immediately tell you that you move the tuning fork to the front of the ear, so that's near the ear canal. And, in a normal, they should still be hearing the sound at this point. So, but you ask your patient if they can hear the sound as well. So so the interpretation of this is, in normal hearing, the air conduction should be better than the bone conduction. So meaning that after you've put it on the mastoid process, once it stops, then you bring it for hair conduction, they should still be hearing that. And you would regard as a positive rhino. Now bear in mind that term positive in this case is normal. So that's what you expect in normal people. And then and then once you do it and you're having the bone conduction more than the hair conduction, that's a negative Rinne, and you expect to see that in conductive hearing loss. Now, in sensory neura, sometimes it's the way it presents, it could, because it depends on, it's quite subjective. So it depends on, some patient have got sensory neura. Patient might just still tell you that the air condition is better than the bone conduction, but it's just that the difference between that and normal hearing is that it's going to be diminished. Like it's going to be quite low in terms of the sound that they hear. Next, please. Now for Weber's, one thing I also, a way that I also understand this and what helps me with is You use your Rinnes to differentiate between the two, but Weber's will help you to calm down on where exactly, the problem is, the organ that the side of the hair, or if it's both hairs, where the problem is. So for Weber's, kind of you're using the same tuning fork, you strike it, and this time around you place the base at the middle of the forehead, and you ask your patient to tell you where they're hearing the sound. So are they hearing it more on the left side, or just on the left side, or are they hearing it on the right side, or is it central? So they would tell you it's in the middle. It means that it's equal. Now, the normal hearing is that it should be central. They should be hearing it somewhere in the center, right there at the back. And so it means that it's equal on both sides. That's normal. But in conductive hearing loss, that sound we localize to the affected ear. So let's say this patient has got wax impaction. It will localize in the left ear. So it will localize to the left ear, because I've done a table as well on different examples of this hearing loss. So we'll be able to put them together to know that in conductive hearing loss, these are the different conditions, and this is what you expect. So you would expect your sound to localize to the affected ear in conductive, and in sensorineural, you expect that the sound will localize to the normal hair, so the unaffected side. Next, please. So this table here is just showing us the different common causes of hearing loss, and I've broken that. Well, it's not my picture. This is from website. This from Google. So it's for conductive hearing loss, as I've mentioned. It could be issue from the outer hair or in the middle here, and an example from outer hair is waxing, anything that blocks that kind of auditory meatus. So it could be wax impaction, it could be patient that's got polyp there, tumor, or otitis external, that the whole canal is all inflamed and stenosed, and there could be stenosis, and there could be congenital cystosis. It could be a patient who's had a trauma, a boxer, for example, or there is bleeding there, there's blood clots there just sitting there. So that's for conductive. And in the middle here, if there is tympanic membrane perforations, for example, these are all still conductive hearing loss. If there is cholesteatoma, if there's been instrumentation or pressure trauma, barotrauma, all that, otosclerosis as well is an example of conductive hearing loss. And for our sensorineural, we've got the presbycusis, you've got your acoustic neuroma there, you've got your Meniere's disease there, you've got your ototoxic, medications as well. So that is it. Oh, and also there is a different classification as well, which is like mixed. And for the example for mixed, they say sometimes in some infection, in some rare genetic conditions as well, they could give a mixed picture. Thank you.